Hey everybody, welcome back to the channel. My name is Reed, and before we get started, don't forget that you can download the PDF of today's ECG down in the description below and follow along and make your own notes. And while you're there, consider subscribing to the channel and liking this video to help support the channel. So let's jump into it. So first thing I like to do is I like to look at the forest and kind of get an idea of what's going on with the strip and the trees of the forest or my QRS complexes. And so I go to lead 2, I see I've got a regular rhythm ticking along at what seems to be a normal rate, but we'll calculate that here in a second, and it seems to be normal the entirety of the time. My rate, what I like to do with my rate is find a QRS that lands on a solid line. So I've got maybe this one. I've got an average rate of 300, 150, 100, 75, just under 75. We'll call it 73 beats per minute. So we have a regular rhythm with a pretty normal rate. My QRS seems to be a little bit wide as I kind of glance through. Seems like my QRS could be maybe a little wide. We'll kind of get to that later. But I do see some P waves, right? And that makes me happy. Let's take a look at those P waves, right? What is the atria doing? Well, my atria has P waves that are upright in lead 1 and are upright in AVF. Remember that lead 1 is going to the left, lead AVF is going down. So if you have P waves that are upright in those leads, it tells me that the P wave is going down to the left, which is what we should expect when a sinus node is located high in the right atria. It's the only way it should go. So that's good. I like to measure my intervals next, but really I like to focus on the PR interval first. Why? Because that represents my AV node, and we know that the AV node is the next thing that's going to capture that signal and send it down, right? Think anatomically, and your ECG approach will not falter, okay? So I've got a PR interval to look at my AV node function, and so maybe I'll choose here, this one right here in lead 2. And so my start of my P wave is right on that solid line. My QRS starts a couple lines after 5 millimeters. So I would say that is like a 7 millimeter PR interval, 40 milliseconds per millimeter. So if I do the math, doing public math is scary, we've got 280 milliseconds. That's my PR interval, is 280 milliseconds. That's more than we want to see. Usually we want to see a PR interval that is less than 200, in between really 120 and 200. And so I see this long PR interval, and I'm like, well, I need to figure out what's the behavior of the AV node. Does it stay at 280 milliseconds every single time, or is it changing, right? Well, we have a regular rhythm, so that makes me think that's probably staying. And if I kind of just march out these PR intervals, if I just look, I march through the rhythm, I see they're not changing at all. And I see that no P waves are dropped. All P waves conduct to QRS complexes. And so this is a textbook first degree AV block, okay? AV node is just taking a little longer, right? This is my AV node proper. That's what delays my signal so that the ventricles can fill. It's delaying it for 80 more milliseconds than it should be, okay? Alrighty, and so now we kind of move on to our QRS evaluation as the AV node passes the signal down to the ventricles to depolarize. We said we thought maybe our QRS duration was a little bit wide. I would agree. It looks to be about 4 small boxes, so my QRS is about 160 milliseconds in duration, which is also a little bit too long. Usually we want it to be within 120 milliseconds, and so I started thinking to myself, well, I wonder why that is. Well, let's look at our axis, right? So our axis is isoelectric in lead 1. It's upright in AVF, and so that tells me that my QRS axis is going straight down towards AVF, perpendicular to lead 1, right? Because it's isoelectric in lead 1. It's not more positive or more negative in lead 1, which means it's perpendicular to lead 1. So I've got a QRS axis that's right at positive 90 degrees, right down the pipe of AVF. And it's a wide complex QRS. So why is an AV node that's passing signal down to the ventricles, why is my QRS taking too long? Right, well, that tells me that there's probably some type of conduction disturbance or bundle branch block. And the first thing that you are all probably noticing just as much as I am is in V1, I'm looking for a bundle branch block in V1, and I see I've got an R, S, R prime. See that little itty bitty R, S, R prime. And so that R, S, R prime in the setting of a QRS that's prolonged is really good for diagnosing right bundle branch block. You can also see in right bundle branch blocks, you get these slurred S waves in the lateral leads, which are leads 1 and AVL. Why do they happen in lead 1 and AVL like that? Well, lead 1 and AVL are lateral. And if my right bundle branch is blocked, I get rapid depolarization of the left ventricle, and then later on, so later on in the QRS, I get slow cell-to-cell conjunction, the conduction through the right ventricle, and so that's why we get these slurry negative forces away from those leads, because it's going away from them. Okay. Next thing we're going to do is we're going to evaluate our QT interval, right? What you can do is you can just kind of go between two R to R intervals, what I like to do, and I like to make sure my QT interval is at least terminated by the midpoint, which it is. And so the last thing we'll do is we will evaluate for pathological Q waves, ST and T wave changes. I don't see really any significant ST segment elevation here. I do see maybe a pathological Q wave here in lead 3. Is that a pathological Q? Well, it is more than 2 millimeters, which is, maybe a metric that you can use. And, potentially we could say maybe this person had, disease of the right coronary artery previously. Why? Well, they do have a first degree AV block. We know that the AV node is supplied by the RCA, and there is some pathological Q waves in the inferior leads, which are leads 3. And so maybe they had some prior right coronary involvement. It's really hard to say. I would just look at serial ECGs and see what their previous ECGs had looked like, right? And in the setting of a right bundle branch block, you're going to have these strained, T waves that are going to kind of be in the opposite direction. And so with bundle branch blocks, sometimes it's better to get, if you really want to look for ST and T wave changes, to get serial ECGs. So, but, I'm not going to really call this RCA thing right now from like a prior MI, right? Remember, pathological Q waves represent prior myocardial infarctions from an age kind of undetermined time frame, right? Just tells me that conduction through that part of the tissue isn't really effective, right? And lead 3 being all the way over here tells me that if there was any, it would be right ventricular involvement, most likely, or inferior. So what's our final diagnosis here? Pretty simple, straightforward ECG. Obviously, you're going to interpret these in the clinical setting. We are not in the clinical setting. We're just interpreting ECGs. So what do we have? We have a sinus rhythm at a rate of 73 beats per minute. We have a first degree AV node block and a right bundle branch block. Questionable inferior pathological Q changes. So hope this helps. And if you have any questions about this strip, put them in the comments. I'm so happy to make these videos, and I have so much fun. So if you have any feedback, I'm always down to hear it. And yeah, we'll see you on the next video. Have a great day.